All right, DSM-5's next category of mental disorders is anxiety. So anxiety disorders. Several types of anxiety disorders, but something to note about anxiety disorders is that they're the most commonly diagnosed mental disorder in the US on a year-on-year basis. So something like 18% of the population gets a diagnosis. 1 out of 5 people gets some sort of an anxiety-related diagnosis. That's the annual prevalence. So like about 1 in 5 people you see walking around the streets is anxious, is having a real difficult struggle with anxiety. Now, what is anxiety? If you look up some of the symptoms, it'll be like, oh, you have increased muscle tension, right? You got problems concentrating, your thoughts are kind of going around. You have like excessive worry or anxiety about outcomes that are going to happen. You have fatigue. You might feel restless. You might have problems sleeping. You might be irritable. Do you think you know anybody like that right now? Our society is in an anxious place. Our world is in an anxious place. And it is a really bad thing. Anxiety represents you're in a heightened state of arousal. And that heightened state of arousal is bad for you, right? The stress hormones, as we learned from Sapolsky and his baboons, it has a deleterious effect on your overall health, on your mind, on your brain. It kills brain cells. So that high level of cortisol, the glucocorticoids washing across your hippocampus, are gonna cause you some problems in the long term. So it is important that we discuss how to deal with anxiety later. So what is anxiety disorder? Anxiety disorder is a whole bunch of things. One of them is a generalized anxiety disorder. Now, a generalized anxiety disorder is that somebody walks around and is worried all the time. And for no good reason. It's not like they're specifically worried about the economy or they're specifically worried about the virus. This person's worried all the time. If everything was in order, they would worry that there was nothing going wrong. That's the type of diagnosis for somebody who has generalized anxiety disorder. This gets in the way of normal human interactions. And so it needs to be addressed through treatments. All right, so that's one type of anxiety disorder in the DSM-5 under anxiety disorders. Another is phobias. So specific phobias, things like acrophobia. Acrophobia is the fear of heights. Think acrobat, right? Somebody who's up in the air twirling around. Things like hydrophobia, fear of water. These are specific things where they make people scared. Arachnophobia, right? If I'm going to draw a spider. You ready? I'm drawing it. Does that scare you? What if it like jumped out at you? I'm messing with you. If you have arachnophobia, I apologize. But what I want to do when we talk about treatments is how do you get somebody to overcome this particular type of disorder, anxiety disorder? Again, 1 in 5 people are walking around. This is all pre any of this lockdown, any of this virus stuff where I had to teach online now. People were walking around stressed by life. Now, what do we do about that? How do we use psychological interventions? That'll be the next topic, treatments, to help people thrive, help people improve their overall functioning and decrease the amount of stress they're experiencing. 2 other disorders that I want to discuss that are under the umbrella of anxiety disorders are panic disorder and agoraphobia. Agoraphobia is a specific disorder, but it has some roots that are really interesting in social phobias. Agora is the Greek word for the marketplace, and fear of the marketplace, of the agora, is one of the things that psychologists and psychiatrists have to deal with for folks these days. It's going to be something that we're seeing a lot more of because now there's actually more reason to be fearful of actual things in the marketplace that are harmful or potentially bad for you. Whereas beforehand, agoraphobia was not necessarily something you'd see a lot of. It would be more social phobias, fear of meeting new people, stuff like that. But nonetheless, the treatments of all of these are gonna be similar because the anxiety is this worry, this excessive worry. One that's not necessarily like the others is panic disorder. So it might be rooted in an anxiety-like state of being that people who have lots and lots of anxiety or generalized anxiety disorder experience more panic attacks than others, but what they experience is tremendously disconcerting. So imagine this. I know you're watching this pre-recorded video, but what you don't know is the world is going to end in 5 seconds. Meteorite's coming, just like Armageddon. Bruce Willis isn't there, you're gonna die in 2 seconds. What? The unbelievable surge of adrenaline, the unbelievable increase in your sympathetic nervous system's arousal. If you thought you were gonna, it didn't happen. That was a lie, that was a joke. But if you felt that that was true, if you started to experience the world as if it was about to end for you right now, that would be what a panic attack would be like. Now, it's not the same for everybody, but generally speaking, it's this intensity and this feeling of something's very wrong, specifically physically. A lot of people complain of heart palpitations, that they feel like their heart's gonna stop, that they're gonna stop breathing. They get very anxious about dying right now. Now, just to be clear, none of us get out of this alive, right? We're all going to die. But you shouldn't sit there with death anxiety so much that it paralyzes you all the time. In fact, we all pretty much go about our lives not thinking about the end. These folks are confronted with it as though it's the last moment right now. And that's terrifying. And they act like it, and it's debilitating, and it causes them lots of problems in their day-to-day functioning. So panic disorders is another one that's separate from sort of the generalized anxiety and those social phobias and those specific phobias. But panic disorder is one where the treatments are also going to be different than necessarily the other types of anxieties. We'll get to that in a bit. Next thing is OCD, Obsessive-Compulsive Disorders. These are disorders where people have obsession. They can't stop thinking about something. Typically something worrying, right? It's not like they think about the wonderful love of humans for one another, right? They're obsessing over something constantly. And then the compulsion is that they feel this motivation, they're compelled to do a particular type of behavior. And all of this is about those obsessions. If they don't think about it, they'll get more stressed. Or if they don't do the compulsory behaviors that they're motivated to do, they'll get more stressed. So they're kind of trying to self-soothe to avoid anxiety, right? So I always thought of this as an anxiety disorder because they are basically self-medicating through mental or physical behaviors to sort of keep at bay the anxiety. Also, the OCD is just one diagnosis in the obsessive-compulsive disorder and related disorders category of the DSM-5 that includes other things like hoarding behaviors. Hoarding behaviors, you've seen these shows on TV. It's sad that they make fun of them, but it also is enlightening to understand how debilitating a hoarding disorder could be. I'm part of something called the Brain Health Registry, where I'm a participant in. UCSF is tracking people's brain behavior over time, and then part of that study is a hoarding behavior one, and I always answer that, right? I get these emails and it's like, come take these cognitive tests online, and then they track you over time, and they have all your demographics, and they're trying to get sort of a cohort look at how brains age. But then one of the studies that got tacked on, and you have to answer these questions every time you do this stuff, is a hoarding disorder one. And it's like, do you hoard things? And it's like, no, I don't hoard things. And then you have to answer 5 more questions, then it's over. But if you answered yes, there would be this intense level of surveying you about what type of things you hoard. They're really trying to understand hoarding behavior from a neurological standpoint. That there's something about the hoarding behavior that might be an evolutionary thing. People who do hoard are hoarding and have intense emotions surrounding the things that they have claimed, stored, cataloged, and cluttered around their environments. Maria Kondo would not like to go into these houses, but that's hoarding disorder, and it's related to a compulsion, right? They're obsessed with material things. They're compelled to keep them. they have newspapers from 1948 that aren't like special newspapers with something that really happened cool in, back in the late 40s, but they're keeping them and they haven't seen them for 28 years because it's buried under a pile of something, and yet they can't get rid of it because they have this anxiety to want to keep those things. Another thing in this disorders is body dysmorphic disorder. So body dysmorphic disorder is an interesting one. People who have eating disorders sometimes have this comorbid where they view their body and they like they look at themselves and it is not an accurate reflection like a camera sees me accurately, like sees me, oh no, this adds 10 pounds for sure, right? But somebody with body dysmorphic disorder sees a depiction of themselves and it blows their mind because it goes, that's not real. They see themselves as their mind's concept of their body is that it is grossly disproportionate compared to what they would see in an objective thing like a camera. I remember when my youngest son heard his voice on a video for the first time, and he goes, I don't sound like that, and he got indignant with us. He was so mad. He's like, that's not what my voice sounds like. And we had to explain to him, everybody else hears you like that. It's only you who hear yourself in your head. By the way, I sound fantastic in my head. But then when I hear myself on these videos that I play back, it's kind of stinks. So think of that as, an intensely gross, disproportionate viewing of how their body is. There's even a disorder in different cross-cultural places, specifically in Japan. There's a disorder where people have this body dysmorphic image of their body, but it's isolated to they think that they have a giant finger. And what they're terrified of and what causes them anxiety is that they think that by the way, their finger is not giant, totally normal sized finger, but their concept of it is this huge Takushin Fujo. I forget the name of the disorder, but they have this perception that they have a giant finger and that they're terrified that what they're going to do is it's going to accidentally hit somebody and cause them social discord, right, with that person. And in Eastern thought and more collectivist culture, you don't want to be the disruptive one who's like the standout. You don't want to be the Instagram influencer. You want to be the one who is a part of the group, right? So they have a more collectivist orientation. And so they get anxiety about the possibility that they would disrupt that social order and that it would cause them intense levels of shame, personal shame, for having let their gigantic finger, remember they don't have this whatever huge arm sticking out there that's going to hit somebody and cause them to have problems with that other person and bring great shame upon them personally. That's not real, but they're so anxious about it, it causes them to not go up and meet people or not go in for a job interview or not pursue their education. And that's what a mental disorder is when it's causing that person to lack thriving in their life, to lack the normal sort of pursuits. It's holding them back. It's an impediment to them. So that's one of those things in this obsessive compulsive disorder and other related disorders. And one last one is really interesting because this gets to the biology of it. It's called trichotillomania. So trichotillomania, you can learn that word. It's a fun one to use at Christmas when you go home and talk to your families. But it basically is a disorder where people are anxious, and the way they soothe is they pull out their hair, and then they eat it. Strange stuff, right? But if you pull out hair, if you notice that hurt, right? That's my beard. That hurt doing that, and it doesn't feel good. But they do this almost like people who use cutting to relieve anxiety. They do it like that, trichotillomania, but then they eat their hair. It's strange because it's a non-nutritive substance, right? This is I don't know what that's made of, like keratin or collagen or something. But it's dead. It's like skin cells that are dead. So eating it isn't like a nutritious thing. But this is showing that how they're dealing with their anxiety is that they're attempting to feel pain, right? You pull that out, that hurts, right? It hurts your skin a little bit. and then they eat it, right? There's some sort of a oral fixation to relieve their stress. So that's an interesting one, is trichotillomania. Okay, hair pulling disorder, yeah. The next thing we'll talk about are dissociative disorders. Actually, I might skip dissociative disorders and we'll go on to eating disorders, I think, because it's along these sort of anxiety and how do I mitigate my anxiety? How do I control my environment? How do I feel like I have efficacy and power, right? That'll be the next one, eating disorders and power. Okay, now we're going to talk about eating disorders. So eating disorders are called feeding and eating disorders. I have no idea. It seems that's synonymous, but that's what they call it. Feeding and eating disorders. So the first one we'll talk about is one that's kind of related to when I was saying the trichotillomania, pull your hair and eat it. It's related to that. It's called Pica. So Pica is a disease that we see, a mental disorder that we see, behavioral disorder that we see in kids, some kids, and in pregnant women. There are other people that can do this because people are interesting and unique and diverse in their behavioral patterns, but most often we see it in children and in pregnant women, which is really I'm so intrigued by that. Well, what do they share in common? It might not be in common. Maybe I have the wrong perspective on it. But what is Pica? It's a disorder where you eat non-nutritive things. Non-nutritive things like rocks or dirt. Things that don't provide you with any sort of benefit. There's one story of a woman who had Pica and she ate her entire couch. Now you might think, wouldn't that tip off her husband or something? Because he did get tipped off, because what he found was she wasn't eating the upholstery, she was eating the cushion. Just that, just the cushiony stuff, the foamy stuff. And she would pick it out and then eat it and swallow it, right? I mean, this doesn't do anything for you. And then she would, she was doing it so much that the couch cushion was getting disformed, and so she started stuffing it with newspaper. And so eventually her husband sits down on the couch and is like, what is this? And feels it and realizes what she's doing. She'd eaten through a large majority of the couch cushions. That is a really interesting thing, because she's having this compulsion to eat something that's non-nutritive, right? That's why it's a disorder. The next one is rumination disorder. I'm not going to talk about that one. Next one is avoidant or restrictive food intake disorder. This is what I want to talk to you about. And all these folks who say, I'm lactose, or I'm gluten intolerant, or I can't eat soybeans that have been made by corporations that use unsafe industry. Whoa. You are creating a religion out of your eating. It's unbelievable. Now, eating healthy foods is imperative to a good, thriving life. But some of the restrictive stuff is really problematic. If you only eat certain things, I'm only going to eat, I remember a friend who had an actual eating disorder. She had anorexia nervosa. She was restricting herself to eating 2 saltine crackers a day and drinking water. She became very ill because of this, because that's so restrictive, right? You can't do that. So we need to be careful about how we're making these rules for ourselves. Let's talk about anxiety. Anorexia. Anorexia is an eating disorder characterized by really restricting the amount of food you eat. Not just the type, not just this sort of avoiding certain foods, but this is I am in control of my body. This often goes in context with thinking that they're much, much fatter than they are. They're not fat. In fact, when you don't eat, your body eats itself. And so they get cachectic and waif-like and sickly. They look like they're starving to death. They are, because their body is consuming itself. They're not even giving their body enough calories in order to just move around. It's having to consume itself. It's eating through muscle, eating through connective tissue. It's eating through, the whole body is just becoming a waif because they're not giving it enough calories. Now, why are they not? That's the great question. And that comes into how do you treat anorexia nervosa? Well, we'll talk about treatments when we get there. I'm trying to save all of that for later. But it is very difficult to treat, and it's something that you're not going to solve in a weekend. It's not going to be a workshop and solve this. This is going to be a pursuit for you, and you're going to need to learn to become resilient and continually face your propensity towards this type of behavior. The next eating disorder is bulimia nervosa. Now, bulimia nervosa has similarities to anorexia, but instead of restricting food, they go through this process of binging and purging and binging and purging. Sometimes they use laxatives, right? To binge means to eat a whole bunch, and then purge would be to take a laxative so you poop a whole bunch. Sometimes they force their own vomiting. They eat a bunch and then they force themselves to vomit. And then sometimes people who binge and purge will say, you know, I don't like taking laxatives. I don't want to have a bunch of diarrhea. I don't want to vomit. I hate vomiting. I did, however, just eat an insane amount of food. I just binged on all this, right? So what they'll do is they'll then go work out. They become bulimic exercise purgers. They'll work out and they're like, hey, I eat this many calories. I'm going to work out until I'm done burning all those calories off. And they have this very distorted view of how their body metabolizes food and what that binging would cause them to do. So that's bulimia. There is a new diagnosis called binge eating disorder, which basically is just bulimia without the sort of purging part. And that's problematic because all these eating disorders are sort of revolving around your ability to control your own body, what you put into your own body, how you treat it, how you perceive it, how you feel in your own body. And these disorders represent people who don't feel good in their body. And that's a problem that we need to address psychologically. Okay. I'm not going to talk about elimination disorders. We've already talked about sleep disorders when we did sleep, so I'm going to skip over those, right? We talked about narcolepsy and insomnia and sleep apnea and all those. We didn't really talk about sort of the subtleties of sleep disorders, but there could be an entire class on that. I'm not going to talk about sexual dysfunction, again, for the very nature of the fact that I have an entire class devoted to it, and we spend like a week and a half on psychological disorders and sex dysfunction. I'm not going to talk about gender dysphoria. I'm not going to talk about substance-related disorders. We did that when we talked about drugs. So I'm going to skip on to neurocognitive disorders. Remember, we had neurodevelopmental first. The next one will be neurocognitive disorders. This one's very interesting because we're all going to be dealing with somebody in some element that has a neurocognitive disorder. Neurocognitive disorders are disorders that are related to something going wrong with your brain's functioning from a neurological standpoint, but it's not typically something that's happening when you're born, the neurodevelopmental things sort of creating that neural networks in your central nervous system to thrive as a human. This is mostly towards the end of someone's life how the dysfunction takes hold. Dementia is a generalized term that talks about this process, an insidious process. You don't know when it starts, but then what happens is this consistent degradation in the cognitive functioning over time, and it's going to get you. You're going to die of it. Some of them have longer prognosis than others, but some of them have extremely rapid ones, like the Prion disorders. So let's talk first about the most common one that's oftentimes mispronounced old timers, which is Alzheimer's. Dr. Alzheimer was the one who described this particular type of dementia, which now we've studied for years and years and years and understand when you do an autopsy on someone's brain who has Alzheimer's, you will see a particular neuropathology that includes neurofibular plaques and tangles, and this very distinctive look to the dementia is what isolates it and gives the diagnosis. So you can't actually be diagnosed with Alzheimer's while you're alive, because somebody would have had to have sectioned your brain and then looked for the plaques and tangles. And if they don't see those, you don't have Alzheimer's. So given that we were finding behavioral correlates, cognitive deficits that were indicative of a diagnosis at autopsy at death, we changed things up in DSM-5 from the previous iteration, DSM-4 TR. And so now we have this major or mild neurocognitive disorder, and then we say things like due to Alzheimer's disease. We don't know that until we get to autopsy, but there are markers and indicators within cognitive performances that help us to make good bets on what we'll find at autopsy. Similarly, there's another disorder, a dementia called frontotemporal dementia, where only the temporal lobes and the frontal lobes seem to have the type of degeneration that we're seeing in the neurons, this rapid deterioration, faster than just normal aging. Another one would be where we see diffuse means across the brain, Lewy bodies. Those are another particular neuropathology that we can see on slides when we stain neurons and look through the sort of substrate and see what's in the brain and what's going wrong. So there's Alzheimer's, frontotemporal, there's Lewy body, there's also vascular. See, your brain has incredible amounts of vasculature. It uses so much of your blood supply that when things go wrong in the vasculature, it causes the tissues to die off. And sometimes people experience things like major strokes. We talked about earlier in the class, ischemic and hemorrhagic strokes. What I didn't talk about were these things called TIAs. T, transient. Transient's like it comes and it goes. Ischemic, again, that's the same type of stroke as the big ischemic stroke where it blocks a major artery and then, people pass out and can't talk or can't move. This one is a small version of that. It's transient, so it comes in and then it goes. A transient ischemic attack. If people have many of these, what they're doing is they're degrading the oxygenation of their brain, and those cells die at a rapid rate. And if they have a whole bunch of TIAs, then they can get something called vascular dementia. Then there are things like neurocognitive disorders due to traumatic brain injury. If you get hit in the head, or shot with a bullet, or in a car crash, all those traumas to your brain from TBIs, traumatic brain injury, might kickstart a dementia, or might be the etiology of a degrading process in your neurocognitive functioning. Also, we have medication-induced ones. These are iatrogenic. They're caused by drugs that are given to people. And those are difficult because, that means a doctor prescribed them a drug, or they've been taking an illegal drug, and what it's done is it's so damaged their system that they're now in a process of dementing. Then there's something like HIV infection. So if you have HIV infection and you have it go into a stage where it's uncontrolled, you can have real problems with an inflammation of your brain, and the virus eventually gets there. I mean, the same thing's true for if you got the sexually transmitted disease like syphilis. So your first stage of syphilis is typically asymptomatic, nobody sees it. Maybe a little rash is second stage of syphilis, and most people, when they get a rash on their body or bumps all over their body, they're going to go get treatment, which, because it's a bacterial thing, it can be treated very easily with antibiotics. But if you let that go all the way, like the famous Al Capone did, he died of he died of syphilic brain. Like, eventually it got to his brain. So HIV in an advanced stage and untreated, right? With the new heart drugs, we're not seeing very much of that at all. The next one is something that we almost see none of either, which is prion disease. So prions are a specific type of crystalline structure that go in and they invade your brain and they basically break up a neuron, but they're gonna kill you. Prion disease is like you're dead. You're not gonna live. I had one patient that had a prion disease, and it wasn't because he ate bad cow meat, right? There was that scare of cow meat in the UK. I think that was in the early 2000s, called mad cow disease, right? This is a prion disorder, and prions are so dangerous that like when you do, funeral homes can't even take in people who have prion disease because it's so potentially infectious, and you could even burn it and like the prions stay. There's some sort of crazy stuff like that. But my guy that I had, he was a patient at Mount Sinai of mine. He had a prion disease that was actually, when they did the biopsy, he was still alive at the time. They did a biopsy of his brain and they sent it off. I think it was Case Western Reserve. I think that's out in the Midwest. They have a specialized thing and they studied this really, really rare thing, right? Prion diseases are weird to get from environmental stuff. Some people got it from eating, zoonosis may have happened from scabies, which is a disorder of goats and sheep. They get it in their brain. So there may have been zoonosis from that, but who knows? You shouldn't eat don't eat animal brains or human brains. Don't do that. But this guy, my patient, had the even rarer one, which was, it's a familial form. So there's a genetic disorder that causes prions to begin to form in your brain as a result of maturation. And this crazy, crazy rare disorder, it was terrible because, the doctors got this news back of the diagnosis that it's familial form. It's called Creutzfeldt-Jakob's disease because that's, some guy named Creutzfeldt figured it out and had a partner named Jakob. But Creutzfeldt-Jakob's disease, familial form, is a genetic disorder, and he had 3 boys. So he got it probably when he was like my age. He was a very successful guy in New York, living life, and then boom, hit hard with a dementia that just was a rapid decline. I think he lasted probably 3 months. And it was so advanced by the time he got to the hospital and they got the diagnosis and the prognosis, he had lost function and he wasn't going to get back. It was a really tragic situation, but thankfully, so rare. Not something you should ever worry about. Okay, next one is a much more common one, probably the third most common one. The most common is Alzheimer's. Second most common might be vascular dementia, and then the third would probably be something like Parkinson's. Parkinson's is a disorder where, remember, we have the brain and there's this subcortical structure called the substantia nigra, and the black substance, that's the Latin for black substance, it produces dopamine. Dopamine, you get those when somebody gets the likes on your Insta feed, or when somebody says, yes, I swipe right on you, you get that dopamine hit. Dopamine doesn't just give you this good euphoric feeling like you're high. It does do that, but it actually gets your body ready to move. So dopamine has these multiple functions across your neural substrate. People who have Parkinson's disease typically have problems with movement. They have problems initiating movement. And I could show you, like if I had Parkinson's disease and the neurologist says to me, stand up, it'll be like this. So they have problems initiating. Once that movement gets started, or like walking, they'd say like walk, like what you'll see is a shuffling gait. They won't be balanced quite yet, and then they'll eventually get into it. Once they start walking, they can continue the movement, but it's the initiation of the movement that's different. They also have something called cogwheel rigidity. So if you said resist my arm and I just pulled up like that, and you gave the same level of resistance, then my muscles should pull it in a smooth motion. Because of the the degeneration of dopaminergic functioning and dopaminergic signaling in their brain in Parkinson's, remember, it's only this part of their brain that's degenerating, the substantia nigra, or this area around it. The subthalamic nuclei is what we call it. So it's a group of cells that are under the thalamus. Because that area is degenerating only, you'll have something like cogwheel rigidity. A lot of times people that get diagnosed with Parkinson's, the first thing that happens to them is that they fall. They might notice what's called a resting tremor. And how we treat it is you can do psychosurgery where you have a deep brain stimulator. They put in a stimulator and it stimulates the neurons that are still producing dopamine to produce more dopamine. The problem with that is that by the time you notice any symptom of Parkinson's, something like 90% of your dopaminergic neurons are dead and gone. So it's really it's a very advanced stage of the degeneration. So trying to get that 10% to the other 90% work is really difficult. So giving patients synthetic dopamine, dopamine's too big to get across the blood-brain barrier. Go take biopsych and you'll learn about that. So they give them two smaller things that then go past the blood-brain barrier and combine to make dopamine. Okay, so those are the treatments for Parkinson's disease. Problem is, just like all other disorders that are dementias, you're not getting better. Another one is Huntington's disease, which is genetic disorder. And this genetic disorder causes movements. It's chorioathetoid movements. So people with Huntington's disease, they'll begin to move in these strange writhing ways. And then they have neurocognitive degeneration. They eventually die pretty rapidly. Huntington's disease is a really terrible one. And then there's also the other diagnosis is you can have the measles and a broken leg, right? You've heard me say that before. You could have vascular dementia and get Alzheimer's. So there's a potential for both. Really in the dealing with neurocognitive disorders, we've got to say, is this going to be something that's ongoing? Is it going to continue a decline for that person? Because then you need to plan out for compensatory strategies to make that person, you're not rehabilitating that person, you're trying to make them independent as long as is possible and make sure that there's supportive structures around them to make sure that terrible things don't happen. You know, sometimes people who are left alone and are aging and have dementia burn the house down and die inside of it because nobody was checking on them, and their Alzheimer's, their neurocognitive disorder, caused them to not remember they left the stove on. So their activities of daily living become actually dangerous, physically dangerous. And so when you find diagnoses like this, you need to, the strategy for the healthcare community is to come around them and to shore them up where they are faltering, but to allow them to be independent, as functionally independent as is possible. You're not getting better. But there are some drugs that we've seen, especially like with Alzheimer's disease, where you can give a drug and that drug can change the trajectory of your neurodegeneration. The drug that I'm familiar with is one called Aricept, or donepezil hydrochloride. And it's been shown to halt the decline of cognitive degradation in folks who have Alzheimer's, but it only lasts about a year to 2 years. Which is great and wonderful, right? Because if you got a diagnosis of Alzheimer's and you know, like, hey, I'm headed downhill, but right now I'm still capable of doing a lot of independent stuff, I'm going to take this drug and it's going to help to stave off the decline. The end, your end isn't going to change. Again, none of us get out of this alive. But it's nice that there's a medication that you can be treated with. And advances are happening all the time. By the time I publish this video, there might be better medications available for folks who have Alzheimer's to stave off that neurocognitive effect. There's some evidence that treating them with stimulant drugs, Ritalin, might be helpful too. That's tremendously helpful in traumatic brain injury rehabilitation, are those psychostimulants. But that's a whole other class. Now you guys know your psychological disorders. Next, we're going to see what we do to help people who have psychological disorders in the treatment section.